Hello, everyone. Apologies for starting 2 minutes late. Welcome to this month's CareNext Collective. We're experiencing some slight technical issues with one of our guests, but here we are. We're really glad that you could join us today for this really, really exciting topic. So when people hear the word innovation in healthcare, they often think immediately of technology, new devices, new AI tools, new digital platforms. And while technology absolutely matters, if we look at the history of major advances in healthcare systems, many of the most powerful innovations have not been technological at all. They have been organizational innovations, social innovations, and new ways of structuring care. Innovation can mean redesigning how teams work together, how we create new models of care delivery, rethinking how we deploy the expertise of our workforce, or developing new ways to organize services around patient needs. In other words, innovation is often about changing how the system works, not just adding new tools to it. And one of the most important and sometimes overlooked levers for improving healthcare access is how we use the capabilities of the professionals that are already in the system. Across many health systems today, demand is rising faster than capacity. The instinctive response is often to ask, how do we add more resources? But another question is equally important. How do we organize care so that every profession can contribute fully at the top of its scope? When we do that well, we often discover capacity that was already present but not fully activated. So today's conversation is about this precisely, and we will start with an example and then pursue a discussion in terms of how does that work, what are the barriers in the way of that approach, and how can we scale it across the system and professions. So at Waterloo Regional Health Network, oncology pharmacists have helped redesign elements of cancer follow-up care for patients receiving oral therapies. Through a pharmacist-led model, patients can receive monitoring, medication management, and follow-up support through pharmacists working within defined clinical protocols. This approach improves access for patients while allowing the care team to work in a more coordinated and efficient way. So today, we're going to explore how this model emerged, what it took to build trust across professional boundaries, what impact it has had for patients and clinicians, and what it might teach us about how we redesign care more broadly. Because while today's example comes from oncology, the underlying question is relevant across our entire health system. Where else might we improve access and quality by enabling professionals to practice fully at the top of their scope? And so with that, I am very pleased to introduce you to our speakers for today's conversations. Anthony Amadio, who's REN's Director of Pharmacy, Jackie Diebold, who's Clinical Pharmacist in Oncology, Joey Champigny, Pharmacist at the Center for Family Medicine Family Health Team, and last but not least, Dr. Mary DeCarolis, who's the General Practitioner in Oncology. So welcome to our guests. We'll begin with the questions. We do encourage our audience to leverage our chat function. We do have community managers who will be looking at the chat function, engaging with you, and so you are encouraged to post your questions throughout, and there will be some designated time near the end of the session for audience questions. So with that, I'd like to hand the proverbial mic to Jackie and Anthony. Let's start at the beginning. Anthony, what problem were you trying to solve when this model was conceived?
Sure. Thanks for the introduction, Danina. We're really excited to chat about this. For this model specifically, there was two main drivers that sort of lit the fire for us to start this. The first one is the changing landscape in cancer care. Currently, there's over 50% of oncology medications in development globally are oral formulations. And so we're also seeing this locally with oral or take-home therapy is now accounting for about 25% of treatment visits across our health region. And so a big shift from what we've seen historically with patients coming in for systemic intravenous therapy. So that was a huge part of it. And then the second piece is just capacity in general in 2024, we had over 160,000 patient visits for our regional cancer program. And we're seeing continued growth, 5, 7, 8% in this patient population year over year. The oral therapy is a really beneficial new approach in the fact that patients don't need to spend their day planning around it. They don't need to sit in a chair all day receiving their chemotherapy. It's flexible. It fits their schedule. Clinically, it can provide prolonged exposure to the therapy and ultimately is less invasive versus systemic therapy. But there's trade-offs to these benefits. And so the medication can still be significantly toxic as chemotherapy is. As a health system, as clinicians, we sort of lose that visual of patients when they're getting therapy now. So our ability to observe the patient during therapy is reduced. And we know if patients are non-adherent with therapy, the therapies don't work as well. And so there's a risk there. And the follow-up tends to be less frequent than what we've seen historically. And so these things combined put a lot of added pressure on the workload of clinicians, both from a monitoring and follow-up perspective. So requiring a shift or change in how we approach it and what we need to do. There's simply not enough hours in the day for our current or previous model to be able to follow up as consistently with these patients. And so this could absolutely lead to access issues for patients. Reduce flexibility in their booking, shorter face time with clinicians. They can feel rushed when they're there. And so our problem that we were faced was, how do we continue to offer the same high level of care in a growing patient population that was stressing our current capacity? And your intro, I thought, was really great in the way that we looked at an innovative approach versus hiring more resources or implementing a new technology. We did an environmental scan and we turned up numerous examples of pharmacist-led models in Ontario, across the country, that showed reductions in adverse events, that showed improved adherence to therapy, high levels of patient and clinician satisfaction. And so we reached out to the oncology team and said, hey, what if we leverage the expertise of our pharmacists and their ability to manage medications to complement the work that you're doing and enhance the delivery of care by allowing the pharmacist to focus on the medications. And that's kind of how we got to where we are today.
Wonderful. Thank you so much for that introduction, Anthony. Jackie, Anthony sort of hinted already to patient perspective, but if you could take us through what does MAP clinic actually look and feel like from that patient perspective?
Yeah, thank you so much. So we sort of have a different pathway for the patient depending on what medication they're on. So currently in the MAP clinic, we are following patients who are receiving an oral anti-cancer agent for early breast cancer. And we're also managing patients who are receiving an oral anti-cancer agent for CLL, which is a hematologic oncology population. So for our breast cancer patients, what that might look like, they see their oncology provider, whether it be GPO or oncologist. And at that appointment, they would sort of do that high-level scan about whether that patient would be appropriate for referral to the MAP clinic, because not everybody would qualify. And if that assessment is done, patient is deemed appropriate for referral. That conversation is had with the patient to sort of let them know what the MAP clinic is, what it's about, how the shared care model between the pharmacist and the oncologist would work. And then from that point, usually what we ideally would like to do is see the patient in partnership with the physician at that first visit, do a best possible medication history, provide education on the agent they're about to start, and book some follow-up visit. That may be done in partnership with the physician. Sometimes we're doing that ahead of time just on the phone. And then from that point, they're seen every 2 weeks with the MAP pharmacist. And at that appointment, we're reviewing their lab work, we're assessing and managing any side effects that come up, and then escalating the care if they're meeting certain thresholds. We have algorithms that we've created in partnership with the physicians. So when we're assessing some of these side effects, there's, again, certain thresholds that if the patient meets those, it's an automatic trigger for escalation of care. So these these guidance documents that we've created for each of these drugs sort of allows us to follow a framework within our appointments and what we can manage independently as pharmacists and what a physician should be involved with. So that's sort of the patient appointment. So we see them every 2 weeks up until cycle 3 of their medication, at which point they will go back to their physician for assessment. And then from that point on, the appointments get further and further apart based on stability. We rotate our patient appointments between us and the physician. So that's sort of our breast cancer population. For our hematologic patients, the drug that we're following is called venetoclax. And when patients start venetoclax, there's a high risk of something called tumor lysis syndrome. And because of that, we monitor them quite frequently. So we're actually only seeing those patients in the ramp-up phase of the drug. And that entails about 8 visits with the pharmacist, including lab work, within a 4-week time frame. So that patient load or that workload has really been shifted from the nursing and the hematology team to the MAP pharmacy clinic. And I think they've really noticed a huge kind of weight being lifted from that perspective.
Thank you, Jackie. So what I gather from this is that you're, despite the sort of innovative approach, you're being very targeted and you're ensuring that the approach is matched with the specific population needs and the therapies that they are receiving.
Yes.
Between you and Anthony, can you talk us through sort of the early implementation? What did that look like? Was there something that surprised you? Did it require any additional work on the part of the pharmacist? If you can kind of take us through the ramp up of this model.
Yeah, so there was a lot of background work, like Anthony had mentioned, to sort of set the foundation to create the program. Previously, pharmacists were not sort of a bookable provider within the oncology space. So a lot of work was done sort of with our IT team to help set the foundations for the clinic to exist. We do sort of use some of the physicians' order sets to help order our lab work and our return to clinic visits, but we did need a schedule. We needed a lot built and the framework set up so that we could actually see patients and the flow would be appropriate. And so a lot of work was done there, and that was actually pretty surprising how much time was needed to build that before we could see patients. And truly just understanding the workflow with even clerical, knowing that when we place an order, where does that go? And if something breaks down, we're responsible for that. So we need to figure out the next steps and figure out how to fix that. So there was a lot of work done, not only with IT, but clerical as well, really to set that foundation. So I think that kind of surprised me early on how much work needed to be done there. And then I guess something that I thought would have been more of a challenge would have been, how accepting patients may have been to the program, being with their physician for so long, and now we're sort of switching providers or introducing a new provider, I would say. We just didn't know how accepting patients may or may not be. And so far, the reception has been overwhelmingly positive. And even with, the physicians as well, we've seen really great feedback. Sometimes you have some slower adopters, but we really felt with this program, everybody's sort of referred off the hop. So it's been really rewarding to see from that perspective.
Thank you for that. So, yeah, go ahead, Anthony.
I was just going to add one piece to it. I think we found early on, because we were also looking at like a complete shift in terms of moving some protected acts, some from the physicians to pharmacists, ordering labs, interpreting labs, ordering medications. One of the things we initially got hung up on and then we sort of had to work through was when we sat down to map it all out, there was an endless number of if-then scenarios. And we started creating documents that were getting pages and pages and pages long to try to encompass anything that could possibly happen. And so this was initial conversation with the providers because we're trying to understand like their thought process and everything that goes through when they see a patient, and then trying to layer on the pharmacist role. And so eventually we got to a point, and Jackie and the oncologist were really great with this. And I think the initial or the professional relationships that had been previously built over years really enabled us to be successful with this. Is we essentially just said, we need to lean into the professionalism, the knowledge, the skills of the people working here, and we're not going to be able to plan out for everything. And so this is, as Jackie talked about, the escalation and when to bring in. And so instead of trying to nail every single possible outcome, it was more so grouping it. And so trying to work a little bit back and forth there. What it did end up creating, though, is we have extremely comprehensive documents that now other sites want to get their hands on because of the work that's gone into it and how successful we've been with this initial rollout.
Mm-hmm. That's a great segue. Dr. DeCarolis, from the oncologist perspective, from a physician perspective, what made you comfortable with this model?
A couple of things. One is knowing be interacting with the patient. So it's Jackie predominantly, and we were quite familiar with her from clinic. She's very competent. She's very pleasant. So we don't, there was no worry that the patients would not have a good experience. And the second is necessity. It just too many patients with too many treatment options, too many visits, and where do you put them all? It's impossible to fit them into the existing clinic schedule. So there had to be a way to relieve the clinics of some of the follow-ups for these patients that require fairly intense frequency of visits early on, and then they spread out over time. I've actually just presented it to my patients when I speak to them about that will fit into the MAP pharmacist clinic protocol, that I share my care of monitoring this drug with the pharmacist, and you will see me some of the times, and you will, sorry, I have two. So you'll see me some of the times, you'll see the pharmacist some of the time, but I'm always in the background. And I've had no one push back at all about it. They've been quite receptive to that. This is the way care is delivered.
And how did this model change the way you use your time?
That's a good question. A number of things have happened all at the same time that has resulted in the fact that these visits have come out of my clinic space, has allowed those spaces to be filled up with patients that are on chemotherapy. So it was more, not sure how to explain it correctly, but we were at a crisis of expanding options for patients living longer, patients on more complicated treatments, patients needing more visits, and bringing in this new adjuvant therapy that generated a lot of visits. And it was difficult to know how they're going to fit in. And we had a nurse practitioner, but then that position became vacant, so that was not an option. So when this was presented as an option, it was, yes, definitely we want to participate in this because we need help to service all these patients and make sure that they get the care they need.
Mm-hmm. Was there any physician resistance, Dr. DeCarolis?
Not that I'm aware of.
Mm-hmm.
Like, I don't choose to not send anybody to Jackie. Everybody go. I haven't come across any patient who I think, no, I better keep this patient, or they're like, because it is a very defined reason they're going to this clinic. And if there's a problem, if it's not immediate, Jackie sends me a message, we deal with it. And if it's more immediate, she just comes over to clinic and we talk about it. And sometimes I'll go see the patient that she's assessing, and sometimes I'll just give her some advice. So all of the patients are appropriate, and I haven't not sent anybody. to be honest, it's a lifesaver. Like, I don't know how I could service all the patients in the clinic. Like, for example, we had I know this is not related to this topic, but it definitely is an issue of this. The reason why this topic is important is triple negative breast cancer in the neoadjuvant setting changed. Suddenly patients went from 8 chemo visits to 24. So they take up a lot of time in clinic, and then you have these adjuvant patients coming along who need more visits because they need this monitoring, and the physicians need to see that triple negative neoadjuvant on chemo, but the pharmacist can these adjuvant oral therapies. So it's a win-win for both, because I would expect this enhance Jackie's work life, and she finds it more fulfilling. I'm putting words in your mouth, but I'm going to guess I'm correct. And it allows us time in clinic to see these patients, because otherwise I'm not sure what the solution would have been, because it's volume. Like, there's got to be more people delivering the care. And if there's not more physicians or there's not more nurse practitioners, then we have to look at other care providers and who else can help in very defined situations that'll meet the needs of the patient's care safely, and help the team manage that care.
No, thank you for that perspective. Joey, from pharmacist perspective, what does practicing at the top of the scope actually mean in day-to-day care?
Absolutely. Thank you for that question. I think in a pharmacist role, an environment and team logistical flow that allows for that optimal care to be provided to the patient really is the starting point to allow for that. We know that pharmacists have this baseline knowledge and accumulate this experience over time, and can really be valuable in these models where it is really, really insightful. And from a pharmacist perspective, I know that Dr. DeCarolis was mentioning that for Jackie, and I would say the same. It really does improve the quality of our work, what we're engaged in, and our ability to continuously learn and evolve as clinicians, which I think is very exciting, and we are really happy to take that position. But I also think that working at this scope of practice it's important to recognize that, I think it's already been mentioned, there are clear parameters that are set in place to not only protect the patients, but also as pharmacists that are clinicians, feel comfortable and have the responsibility, yes, but have this sense of team that is behind us, that we can communicate with a physician, that we have these parameters that we feel comfortable, but if there's any outside parameters that need to be followed up on, that we have that support and that the patient continues to have safe care delivered to them. So I think really that environment is so important, and it really speaks to the preparation. I've had experience in similar models in cardiology and presently in geriatrics and dementia care, where this comes from experience of anticipating what the pain points are for the patient and how we can actually provide that care. One of the main frustrations for pharmacists often is the delivery of care that is known. We know what to do, whether it's a logistical, whether it's scope of practice that limits us in actually delivering that care. We're waiting for faxes or pages or responses from physicians who know that that's what they want to do. They trust us. They've built that relationship, as was described with Jackie's role, for example. And that implementation just allows the physicians to focus on an increasing burden of patients that are coming in and this volume that they need to connect with as well. So I think it really is this longitudinal model that pharmacists are ideally positioned to provide that follow-up in terms of optimizing therapy. I know in the heart function clinic, that was a big component of making sure that we are getting to those guideline directed doses, but also monitoring for side effects, adverse events, blood work, and making sure that those therapies are both effective and safe. So having an environment and I think a leadership group that supports that, not only from a pharmacist perspective, but from physicians, and that ability to continuously learn and evolve is something that's really gratifying. And I know for me is something that I really value in my day-to-day work.
Mm-hmm. So I think this sets us up for a sort of a larger kind of systems conversation. And so this question really is to all of you. What makes a model like this possible? What conditions have to exist? Because we know that when it comes to implementation and scaling and adoption of innovation, I mean, one of our biggest sort of issues is change management. And Jackie and Anthony, you've hinted to some of the sort of things you had to think through. But if you could take, for all those who are considering undertaking organizational innovation or leveraging professions at the top of their scope, pharmacists and otherwise, what conditions, in your opinion, have to exist to be able to do so?
So I can start with this one and speak to our experience. But I think for if other organizations or places are looking for it, I think what really made us successful was looking internally first and saying what makes our program different or special, or what's going to allow us to be successful with this. And for us, it was the relationship between our pharmacists and physicians in oncology. Dr. DeCarolis pointed to it earlier where she said, I know Jackie, I've worked with Jackie, and so I have no issues sending patients there. And I know that that sentiment is shared. We've had multiple conversations from other providers who treat other conditions within the cancer program that are saying, hey, when can we get access to this clinic? When can we start sending patients to this clinic? And so that trust between professions is sort of the biggest thing for us. Years and years of our pharmacists working shoulder to shoulder with the oncologists, with the GPOs in this setting has led to really strong professional relationships that are rooted in both trust and respect. And so when we initially went to the group, the response was immediately, hey, what do you need from us to set this up? Right. And so like for us looking at it, and we didn't have to pitch this whole case of here's all the literature and all the data that shows that pharmacists can have this impact. That was already sort of known within our group because of the personal relationships there. And so for us as a leadership team, it was really easy I met with Jackie and some of the other members and I said, I don't work in the oncology space. There is little chance of me having more success than you pitching this to the group. And so I was very hands off. I said, here's the parameters that we want to work within. You set it up in a way that would work. And then we just had regular sort of check-ins. And so this model is all clinician provider driven. There was no sort of restrictions put on it from a leadership team. It was very truly designed with how can we support patient care with the experience from the team members? And so I don't think we're so unique that other places don't have these positive relationships, but for us, like that's what made us really successful in starting this. And I think we're starting to see more of it. We've got other groups reaching out to us saying, how can we get a similar model? Where do we get access to a pharmacist? And so it's sort of building off of that and having the teams really work together to come up with a solution versus us saying, this is what we want you to do.
How much of this, if I could ask a follow-up to this, how much about this is really about scope of practice and how much about this is care model design? To any of you.
Yeah, I can probably take some of that. So in terms of scope of practice, our scopes are a little bit different as a pharmacist, whether like where we are practicing, whether it be community versus hospital versus family health team, the scope is a little bit different. Some places also may have some medical directives set up that are in place for pharmacists to kind of practice a little bit more independently, maybe a little bit outside of their scope of what they could do just as a pharmacist. Here, what we have implemented is sort of a directive in which the The physician is delegating tasks to us. So we are able to do a lot of these things. We can make recommendations about how a dose should be changed based on blood work or what symptoms are coming up. We can do all of those things. But now with this additional directive, we're able to do these independently within the patient visit, again, to a certain point, to those thresholds. So part of it is about scope of practice, but also for us, part of it is about how we've developed the program to be able to leverage our skills and almost as an extension in some way to the physician. So there's a little bit of both at play.
In terms of sort of enabling policies and financial models, do the ones that we currently have in place make these kinds of models possible, or they make it sort of more difficult? If you could speak, any of you could speak to that.
Joey's experience working outside of the hospital system is going to be different from Jackie's, as was mentioned, because of legislation. And so working within and under the legislation of the Public Hospital Act, some of the things that would be within pharmacist scope are restricted based on that piece of legislation. And so this is where we need to get a little bit creative with working with the providers, whether it's a medical directive or delegation of tasks. We're fortunate here at our site that we do have a collaborative leadership. We do have teams that are looking to really leverage the skill set of the professionals that we have here. And so we have policies in place that we can build off of, from any microbial monitoring, any coagulation monitoring, medication reconciliation. And so a lot of the structure of what's within this current practice is built off of those previously enacted policies at our site. And it's just sort of tweaking them and then making them function within our space. The financial piece, I think this is where Joey's experience would be very different from ours. We sought out third-party funding to help support the startup of this, but the reason for doing that is we can then demonstrate to the organization a model like this will create efficiencies, will save time, and also in some instances can generate revenue as well. For someone, and Joey can speak to this in much more detail than I could, but someone working outside of the structure of a hospital where they're not looking for efficiencies and savings, like Joey is not going to get benefit from reduced hospital admissions, but we would. And so a program like this that can then demonstrate savings in other areas becomes very financially sustainable. And so it's easier for us in some regards to be able to implement that because we can get that financial benefit from it as well.
So Joey, where else could this model apply across healthcare, if you could?
Yeah, and I can kind of speak to add to the previous 2 points. I think to Anthony's point from a legislative perspective, I think it also starts with communicating what the actual scope of practice is right now in primary care. For instance, I think a lot of physicians are still surprised that we can adjust doses and that there are things that are within our scope of practice that they don't necessarily realize, and then identifying what are the gaps that we want to provide the care that we're looking for. So, okay, you can't order blood work. Okay, well, that's going to be a medical directive or collaborative agreement that we can, again, create, implement in a safe manner with parameters that we feel comfortable for our patients. So I think that is a really good starting point in the ability to have these models exist in primary care. To Anthony's point, also in terms of some of the outcomes we can look at. So for myself right now, working in the MINT Memory Clinics, which is a multidisciplinary physician-led clinic, where a lot of the work that we do is oftentimes between visits. So pharmacists will take on a lot of the follow-up, a lot of the monitoring, whereas the physician will kind of see them every 3 to 6 months for their usual follow-up. In that time, though, there have been publications that do show that in primary care, individuals who are followed by this model actually have reduced costs associated with them. Their ED visits are actually half the cost of what they would be if they weren't followed, because oftentimes they'll just go to ED versus being able to actually just present to our clinic, give us a call, and we actually have access to their information. We're able to make therapeutic substitutions if we need to based on those medical directives that we have. So I think recognizing what the baseline is and then implementing those gaps for the patient. And for myself, in a place where in a family health team, what is the need of the family health team? That is going to be a consideration that might be unique based on where you're working. So for the KW4 region, for example, that is definitely a need that has been highlighted from a geriatrics perspective and memory care in general. But you may have certain communities that really would value having a pharmacist involved in a diabetes clinic, which we have as well, for example, or perhaps it's more cardiology focused with congestive heart failure. So I think identifying the need within your community is a really important step as well. And then really recognizing how can we fill that gap with reorientation of perhaps some of their time in that clinic, and then dedicating the rest of the time for scope of practice that's more traditional per se.
Mm-hmm. Well, what I'm sort of taking away from it, I mean, but starting with raising awareness and around the capabilities of pharmacists will certainly go a long way then once we have ascertained the specificity of needs in our environment, how we could leverage them.
Absolutely.
What are the biggest barriers to scaling this approach? This is a loaded question, I know.
One of the issues we like Joey alluded to it, and I mentioned it, like reimbursement is a huge part of it. Going back to working in a health network or like WRHN, we have staff that are employed as salaried staff, and so their outputs are patient care, but also how do we impact the financial sustainability of the organization. And so the impacts that we have at multiple stages are going to do that. For Joey's perspective, if he can provide value to the family health team, then he can his reimbursement will sort of come from there. But independent clinicians and people working outside of those scope, pharmacists can't bill to OHIP like other providers can. And so the reimbursement for clinical services continues to be a challenge and is a barrier that we run into when we try to link acute care to primary care. And so the model that currently exists that we see across most places in Ontario, and there are some innovators doing different things for sure, but essentially they are partnered with a family health team, they're partnered with a hospital or a health network, because the impact of this outreach into the community is going to have financial impacts on what we do as a larger organization. And so reimbursement, I think, tends to be one of the largest barriers. Joey mentioned it as well too. It like and it came up when Mary spoke about the relationship that the oncologists have with the pharmacists in our site is there's still a lack of understanding to what other profession scopes are, to what ability, what scope they can practice to. And like if we're being totally honest, like a pharmacist is not a pharmacist is not a pharmacist, right? Others will do different training, and same with physicians. Some will specialize, some will spend more time in academia research. And so it's not as simple as just saying, well, you have access to a pharmacist, so you have access to all of these things. Because the pharmacists working in those spaces may not have the training, may not have the additional skill set, or we talked about it as one of the reasons we started this was capacity. Pharmacists in community may not have capacity to do it as well. And so there's a disconnect there between what people are allowed to practice to for scope to what they're actually able to do from training, expertise, skills, capacity, all of those things. And so like large scale rollout of something like this would be extremely challenging. And we even recognize that here. This is why we had a very small group of pharmacists do this. We focused on one disease site to start, and we're slowly expanding out there because it takes time to build up those professional relationships, the understanding of how the process works. It takes time to build up the capacity to do it as well. And so I think the biggest things, and we saw it here as well, we had reimbursement issues. How are we going to fund it? We had capacity and skill issues. And so, and that's within one organization. And so trying to scale that can absolutely cause breakdowns, bottlenecks, and challenges to roll out models similar to this.
Mm-hmm. On the flip side, Dr. DeCarolis, from a clinician's perspective, what would sort of be the encouraging factors that would make or encourage clinicians to trust and adopt a model like this, if you could speak from a larger perspective?
I think the biggest encourager is the effect it has on workflow. So you are able to see more complicated patients. You are able to bring in patients who are having an acute crisis for assessment. And someone else is seeing your, in this setting, adjuvant CDK inhibitor patients on those drugs at specified predetermined times. So it allows you more flexibility with your schedule. But I think it's, you know, it also enhances the relationships between the members of the team, like, and you can see them function in an expanded role, and that's it's nice to see. It's nice to know that those people exist, and that perhaps, you know, with this trial, that there'll be other drugs. And I know I've already asked Jackie, like, what about my neratinib patients? Can you see them as well? So, you know, I've already, for me at least, it's like, I could use help managing these other patients that are on similar drugs. Will we expand to that? So I think it's, you know, it's a nice work environment. It allows you to see somebody else in a different capacity. It's good for the patients to see, I think, that other care providers can also take responsibility for their care, that it doesn't have to just be the doctor.
Mm-hmm.
Yeah, I think it's been a win-win, definitely for me. If I'm speaking just for myself, it's yeah, I've been very appreciative of the clinic.
Mm-hmm. Thank you for that perspective. So we're getting some questions from our audience, and audience is definitely encouraged to leverage the chat and ask more questions as we are entering the last sort of 15 minutes of our session today. So Sorma asks, I'm curious about the change management process following implementation of the system. How did you approach it, and what were some key lessons learned from your experience?
Change management. So I guess overall, again, it really, the process of the clinic has really changed how the pharmacist is involved, especially in oncology, and how we manage patient care. And so I'm not sure if I'm kind of answering the question the way that they're asking. But in terms of change management, like, we've had to go through many iterations. Like, we've had to make sure that what the process we set out to do is working. And there's been times where it hasn't. So we've had to identify what the barriers are. Initially, just this very small example, when we were using the order sets that are utilized by our physicians, there wasn't an orderable in there to sort of have that return to clinic visit be with the MAP pharmacist. A lot of it relied on us changing comments and just modifying what was already in there, and that wasn't working. And, you know, people were being booked to the wrong schedules. So in terms of change management, we really had to make sure that the process and the flow was working. And if it wasn't, we needed to reiterate. We needed to move quickly too, to make sure that this was, you know, efficient and it was working well. Even now, we're going through an even bigger change management process, in that we're kind of utilizing a new system to order our visits, order our drugs, and it's going to be different for everyone. And this is actually going to change how the whole process flows through the clinic, and we're going to have to do some more education. So again, things are coming up constantly where we're having to reiterate. It's getting a little bit more challenging now because our patient load is a lot higher than when we started. It was a lot easier to make changes early on. And that is also why we decided to start with such kind of a focused patient population, because it allowed us to iron out a lot of the kinks up front. Then we could kind of introduce more patients. The patient load is increased. You know, this new challenge is going to be a little bit harder to sort of work through. But again, in terms of that, we've had to pivot a lot and kind of rework as we go.
And I would say, oh, sorry, Joey, just one thing with our process here that I think we don't want to overlook is how thorough we were with our initial process map. So we sat down and said, from the minute a patient is referred to when they complete X number of cycles, who touches their care, right? Who's involved with it, so that we can engage those people early on. So we didn't run into a scenario where we were trying to engage or trying to book a new meeting type, and our digital team's like, well, we've never heard about this. Or we ran into an issue where clerical was trying to book while someone else was trying to book. Or we created a scenario where patients were calling, trying to get a hold of a nurse, then trying to get a hold of a pharmacist or speaking to someone else. And so from that change management piece, I think one thing we really set out to do initially was we wanted to be as thorough as possible into mapping out current state and then future state and engaging the right people early, so that what Jackie's talking about now as we iterate, it's things that we anticipated for the most part, but wouldn't know how they worked until we've done them. We haven't really run into anything where it's like, oh man, we really missed this. And so I think that initial time and effort put out front to map it out was a huge part of us being successful with this.
And I would just add,
go ahead, Joey. Sorry.
Yeah, as just a final point in terms of change management and how it's, I think, a very fluid and evolving space in terms of going back to, again, what is the need? I think oftentimes there may be concern with scope creep and what are we trying to achieve? And I always go back to the physicians and what are we lacking, and what is the ideal care that you would want to provide if you had all the resources and all the times? And oftentimes that's where the physicians will say, well, actually, I just wish I could do this or this and this, but I don't have the time. Oh, wait a minute, actually, we have the skills to actually enhance, not replace, but enhance that clinical care that's being provided and fill those gaps. I think that's a really important point, as opposed to, of course, passion and an interest in the space is very important, but that alone should not be the reason why such clinics are determined. It's actually based on going back to the basics. I love what Anthony just said about mapping out the entire patient journey and then recognizing those patient pain points, the physician pain points as well, and how as a pharmacist we can actually help to solve a little bit of those.
I'll give you that one. Stephen asks if you could give a quick summary of what changes were implemented that would define the scope expansion, and were there specific suggestions that were more challenging to implement that you decided not to?
The biggest change for us was like physically removing the physician from the follow-up visits, and everything that comes with that. And so at these follow-up visits, and there is a need to review lab work, review diagnostics, order labs, order diagnostics, and then reorder the medication. And so while ordering medications is within scope of pharmacists for certain conditions, this was brand new. And so it was, how can we come up with a process that allows pharmacists to practice to their skill set, but now do a task or do a function or a protected act that historically they haven't done. And so the biggest change for us was not like pharmacists doing medication management or partnering with physicians on this, but the biggest change was like actually removing providers from that step and the pharmacist owning it. And so how do we continue those open communication so that the physician is still actively involved? Because to Joey's point, he's mentioned this a number of times, we're not trying to replace what physicians are doing here, but we're meant to enhance it and complement it. And so when we talk about medications, the pharmacist is your medication expert. And so how can we enable them to practice to that? If they need to know what the medication is doing, then they need to order diagnostics. They need to order labs. They need to be able to assess those. And so eliminating that step of having to run everything by a provider to meet those requirements was the biggest change for us in this.
Sarah says, where are pharmacists seeing patients from a physical space perspective? Are you utilizing clinic space in the pharmacy department, or was a new space developed?
Yes, clinic space is a hot commodity around here, as I'm sure it is at most cancer centers or, you know, any clinic at all. We are fortunate to have a few quiet rooms within our cancer center. And because we don't need an exam table, we don't need all of that space to actually kind of perform our assessment. We're able to use these smaller rooms, literally just table, chairs, sit down. We have our laptops. We're able to kind of perform these things. And if we need to, we have, again, certain parameters where we're doing vitals. So we just kind of wheel our blood pressure monitor into the room. So we're fortunate to be able to use this space. It isn't dedicated space to us yet. So there has been a few instances where patients may be utilizing the rooms. So we just kind of pop into another one if available. But as we sort of grow, we will have to keep reevaluating part of that change management to make sure that's still working for us. But as of right now, we're just using one of the quiet rooms to see our patients.
And one of our anecdotal measures of success for this clinic is the fact that Jackie doesn't have space to see patients, because where providers historically would have seen these patients in clinic, they're now seeing other patients, as Dr. DeCarolis mentioned. They're seeing more acute, more complex, they're seeing new consults. And so what we've sort of seen here is the fact that we're getting bumped out or needing to do more virtual or phone follow-up, it actually means that we're achieving what we set out to do, which was offload some of this more medication-focused work from providers so that they could continue to see other patients. And so while Jackie tells me every single day that she doesn't have space to see patients, it's actually a positive thing because it means that we've been successful in increasing throughput and capacity and access through the entire cancer program.
This brings up a really important and interesting perspective. What role has technology, digital technology in particular, played in this model?
Initially for us, it was the pathways of getting patients to the spaces they need to be at the appropriate time. And so how to book, how to, who needs to be involved, who's seeing it, those types of things. And so we really leveraged our digital team to build a pathway through Oracle. And then the other thing, and Jackie and Mary can probably speak to this better than I could, but their ability to communicate through secure messaging channels, through other things within our system, to run things by each other quickly, where an appointment may have taken Dr. DeCarolis or her colleagues 5, 10, 15 minutes to see one of these patients is now taking a 10-second message through our messaging center, where we're able to sort of communicate, hey, saw this, have this question, what are your thoughts? Think it's great, go ahead. And so technology has really improved sort of that flow and access, and really enhanced our team's ability to communicate.
Tom, who by his own admission is already a co-investigator on the residency project at this clinic, is asking, what are the plans for examining specific patient outcomes from the clinic, such as adherence to medication, time on therapy, survival outcomes, etc.?
Yeah, if Tom is willing to co-investigate in another project next year, we're hoping to look at all of this stuff. Initially, what we really wanted to do was get a sense of the impact on access flow, time, what is the pharmacist doing, how are they spending their time, what things are they doing in the clinic. And so that's sort of our initial look at this data. Once we start to grow it and expand it, we'll have a lot more robust data to look at exactly those outcomes that Tom is referring to.
Manor says, to help scale this type of model in a community setting, I feel better communication strategies are needed, especially to develop a better relationship. In a FHAT or institution, all providers have access to doctors' notes, labs, etc., or easy ways to contact the provider, unlike community. Any comments to Manor's point?
No, it's valid. so much easier, and we do it here across our health network, and we're not unique in this, but we essentially, we've moved to a decentralized pharmacist model. Our pharmacists are out on the units in the clinics working with providers. It's really hard to develop like consistent, lasting professional relationships when the only communication you have is over the phone via fax. And so I don't have a good solution to overcome that. But I think it's attending events in community. It's participating in education events, whatever it may be, where you're able to develop relationships with these providers. It's consistent communication back and forth. How to do that personally and individually, I think, is going to depend on what your model and your practice is. One thing that I do think, if we're talking about large scale, that is important is like innovative ideas in clinics that are doing this stuff, that are willing to then share how they did it and what the impacts are. And so the reason we were able to get this off the ground is because other people have published similar models. And so we didn't have to do a full 18-month, 2-year proof of concept. The concept is there. We just had to adapt it and build it. And so I think a big thing for large scaling this is research, is innovators that are willing to host, like be part of events like this, go and speak at other sites, sit on panels and share their experiences. I think that's sort of the way to do it. If we can make it easier for people to access data, like objective data around impacts and what that can do, like to Dr. DeCarolos's point, if someone goes to her and says, hey, I saw this clinic model that shows it can reduce physician time in clinic by 6 hours a week, like that's something that's going to speak to them and be like, oh my gosh, I'm 100% in, right? And so Joey mentioned it as well. How do we go back to what's the initial problem? What are we trying to solve? It's patient care, it's access and flow, it's capacity. And so when we do hit on something like this that has worked, being willing to share that and connect with other people on and consult on how to do it, I think is really a good way to expand these.
Thank you all so much. So this was really a fascinating conversation that highlighted an important shift in how health systems think about capacity. Clearly, improving access is not only about adding more people, it's about organizing care differently, aligning the skills of our workforce with the needs of the patients. It shows that innovation in healthcare is not only about technologies, often it's about redesigning care so that the right expertise is used in the right way. I think it also reminds us that good ideas are not enough, right? Real innovation requires changes to workflows, to roles, trust, policy, operational support. In other words, innovation is as much about implementation and system design as it is about invention. But more broadly, I think this example shows that meaningful innovation often comes from recognizing underutilized capacity already within the system and organizing care differently to create better access, quality, and experience. And I think the MAP clinic really offers an example of how redesigning care around team capabilities can expand access while maintaining quality and safety. So thank you very much for sharing with us so generously this perspective. Before we close, I want to preview also our next session, so please join us in April. We will be exploring one of the most significant shifts now emerging in healthcare, patients using AI as part of their healthcare journey. And what does that mean for clinicians, for health systems, and for future of care? We will be joined by futurist Dana Hayat, author Ed Marks, patient advocate Alina Nadim, and Dr. Payal Agrawal. So thank you again so much for joining us today. Thank you to our guests, and as ever, thank you to our presenting sponsor, Manulife Canada. Thanks all.
Thank you.
Thank you.